Yes. That you are here. Okay, I will confirm that to your wife, don't worry. Okay. Now, it's a great privilege for all of us, and mostly for me, because 21 years ago, we had a new consultant appointed in Great Ormond Street Hospital who came and changed the view we had on how to diagnose congenital heart diseases. The very famous for many reasons, not only as a physician, but also as a basketball player in the national team of Czech Republic a few years ago, okay, the one and only Professor Jan Marek.
Thank you, Andreas. And it's been really a privilege to be here, and I'm very happy to share my experience. So I'm going to deliver two talks. The first one, it's about imaging. The other one, it's the imaging and more science. And so what I want to do, I want to. How can I move the slides forward? No?
Sorry, it's here. Someone left the door here.
So I'm going to kind of encourage you to it's about 3D echo mainly, and I want to encourage you that 3D echo is the best technique to understand the LVOT. And I'm starting this picture, and I know that Bob Anderson is very keen to use the CT to emulate his pictures and describe the anatomy, which obviously it's very great, but unfortunately he didn't mention the echo at all. And I want you to encourage you that actually 3D echo nowadays, it's absolutely brilliant. You see, there are the few new equipments, and I'm happy to say I don't have any financial disclosure to make, so that's nothing I would support any of the industry. But these are the images nowadays which we can get from the new machines. You know, the brand new machines, Pioneer, which is absolutely fantastic. And then we have new probes. So we have from Philips and from GE, we have probes that we can insert into the not even the 5 kilos. I'm happy to use it in the 4.5 kilos. They are small, they are very flexible, they are equipped with the OR Doppler, and they offer a lot of views which you can use to get the optimal picture. So we have the fixed tomographic crop planes, and then we use the focused cropping to get the images, and what you see already in this picture is the nice view on the bicommissural valve in this case. And the beauty is that you don't really need to see the multiple 2D views. This is the classic terminology, what we've been using, how to classify the aortic valves. Unicuspid, bicuspid, functional bicuspid, tricuspid, but I'm already telling you we are going to change it completely. So we have the very different view, and that's mainly because we want to support those who treat the valves, right? So if you have the catheter interventionist, he usually doesn't care, you know, how many leaflets and how many commissures, how good the commissures are. But it's important for a surgeon because they mainly repairs the commissures to ensure that leaflets open and close appropriately. So we changed the paradigm and changing the terminology, focusing mainly on the commissures, because this is much more important. And I want to, again, encourage you and to show how we do it, because this is important. And once you become friendly with the technology, it takes 5 minutes to get the nice picture. And this is the first example. We use the oblique views to look at the commissules. So it's very different. It's very, very different. So we go and we rotate the probe and crop the probe to understand every single commissure, respectively, whether it's 1, 2, 3. We look at the extension of opening. We look at the heights of the leaflet, because the leaflets can be resuspended. And of course, we look at the quality to ensure that the margins are smooth, or to identify the fibrotic nodules. So this all can be learned easily from 3D, particularly the 3D TOE. So this is again how we do it. So you see the commissure very beautifully. It opens to the annulus. So there is nothing wrong with this commissure. It reaches the annulus. Height is very good. And it's easy to see it, understand, and it's real. There's no speculation. In this case, and think about what you see. So in this case, the commissure has the incomplete closure, doesn't reach the opening, the annulus, and there's little fibrotic nodules. Do you see it? Do you understand what I'm showing you? Because some people, they don't have the good 3D perception, so this is really important, right? So you see, so the annulus is here, the commissure opens up to here, and there is the nodule. And this picture shows the two commissures. One commissure, which actually I sliced because it's very hard. Leaflets are well preserved. But this commissure is very shallow, deep down in the sinuses. And it's very shallow, so that will be difficult to open it up because it's very short. So that would require, I'm fine, thank you. Yeah. So this is what we want to see, and you can use the adult 3D probe, you can use the pediatric 3D probe. So in fact, you have such a good pictures in every chart from the 5 kilograms. Not difficult. It's just way how to do it and to understand what you want to see. So let me give you the case. So, and I want to be more interactive. So tell me, how would you describe this valve if you see the patient in your clinic?
Bicuspid aortic valve.
So if you look at the top black and white picture, which would be your routine 2D echo scan, how would you describe it? Ignore what I have said.
Unicuspid,
I would say that it's a tricommissural.
So many people would say it's bicuspid because you see the opening like this, right?
like a fish mouth.
No, but there are 3 separate commissures.
So the
They
question
are
is,
fused, but so
and then the
functionally-
question, you say commissure they are fused. Why do you think they are fused?
because
Do you
it's
see fused commissures?
so it opens like a unicuspid, essentially, functionally, but I see 3 separate, like leaflets.
So you are, in general, you are right. The only commissure is here. There's no other commissure. There's the one raphe here. There's the one raphe here. So unicommissure valve with the 2 raphes, right? So if I speak to a surgeon, is that the chance to open up? Is it a fused commissure? No, because the fused commissure, you would need to see 2 commissures which are fused together in the view that the surgeon can open it up. But this is not the case, so there are 2 raphes, right? So this is unicommissure valve, single commissure between non-coronary, left coronary, typically 1 or 2 raphes. So this one has the 2 raphes. One is the little higher up, the one 12 o'clock. the other one is hardly visible, so they might be the bit of the shallow tissue, right? So you can really appreciate because you have the good depth perception. So you see all packets, the sinuses, and you see at the bottom of the sinuses. So this is very important, because if you speak to surgeons, so then you can really give him the good idea, good understanding. So we are changing the paradigm. So we use the description based on the commissural, uni, bicommissural, functional, bicommissural, tricommissural, and then we differentiate between the raphe, which can be open, or you can have the fused commissural, which can be open. But again, you need to see the margins of the leaflet reaching the annulus, and the surgeon potentially can open it up. And you know, if you open it up by 1 millimeter, you significantly open the effective orifice. So sometimes even the small conservative operation may delay the Ross procedure. And you know, the Ross, we are always concerned because we start putting the homograft, right, or RVPA conduit. So this is the example. So this would be our complete assessment, 2D, of course, then 3D, and then you can use the 3D also with the cold Doppler to assess where exactly the regurgitant fraction is. So this is about the valve. You can read many articles about the subvalvular obstructions. There are the different types, typically fibromuscular shells. They are eccentric, mainly extended from the intraventricular septum. Sometimes they are membranous, but these are quite rare. Sometimes they are the very diffused muscular tunnel. You have heard that you might have the subaortic conus. And do remember, old books, they say if you have double conus, this is the typical for double outlet right ventricle, which is complete nonsense, because you can have the subaortic conus completely committed to the left ventricle, even without the ventricle septal defect. And then we have the secondary obstructions, typically ABSD. How come I will show you the cases or complex transposition double outlet right ventricle. You need to be very, very careful. So again, you need time, you need to look at the valve and describe what you see. This is the boy who was referred for balloon, straightforward, and there was the colleague of mine, they say, well, I can do the balloon tomorrow. It's not valvular stenosis, so it's the typical membrane attached to the aortic valve. Yeah, you can clearly see it's the membrane, and the leaflet is not moving because it's adherent to the aortic valve. If you look at the short axis, so you see the membrane, complete circular membrane. So then I asked surgeon that I believe this can be easily removed and shaved from the valve. And this is the outcome. So the valve was completely fine, tri-leaflet, and there was no obstruction whatsoever. So they are the tricky patients. So this is why you need really the good quality echocardiogram. This is the AVSD. And then you can suggest that the LVOT, it's quite narrow, but it's difficult really to say, is it the membrane or is it the accessory tissue from the left AV valve? And this is again for you to understand how we do it. What is the surgical approach? Surgical approach is through the aorta. So we try to emulate the view through the aorta, always. And that's unfortunately, it's a bit jerky. So you see a little bit of the valve, but underneath the valve, there is a very significant shelf from the septal side. Yeah, you understand it. So open up, resected the aorta through the aortic valve. You see there's the quite extensive subaortic obstruction. So we try to help the surgeon that he understands what he's going to see after the transecting the aorta. And these are all the surgeon's views. So you have the mitral valve posterior, in posterior aspect. The hypertrophic cardiomyopathy can be very challenging and difficult also in terms of the treatment, how to treat the hypertrophic cardiomyopathy. This is the case with the excessive septal asymmetrical hypertrophy. So we look at the LVOT really in detail because we can have the mitral valve abnormal. Sometimes the subaortic region can be very crowded, and we need to understand because the many patients are referred for myectomy. So we need to ensure that we are not going to damage the mitral valve. This is very important. Conventional assessment, the typical procedures. Then you have on the still frames, you see the posterior deviation of the mitral regurgite. You see the turbulent flow within the LVOT. In the 2D, you see the sum complete or incomplete, and then you have the dynamic acceleration within the LVOT, double envelope, last picture, tracking simultaneously mitral regurgitation. Then we move to the more advanced scan, and because of course we are interested how much fibrosis is in the septum, and the golden standard nowadays it's speckle tracking analysis, because then you can clearly appreciate that the septal myocardium, it's fibrotic, there is very low strain, and you see it on the bullseye. The next step is that you can stress the patient. You can do the Valsalva. We are lucky because I developed a stress echo clinic for children. So the hypertrophic cardiomyopathy, it's the one of the indications. So we have the device is the semi-supine position, the bed that they can cycle, and because as you know, children can't do the treadmill walking test because of the rapid deceleration of the heart rate, and then you can get the good results. And we know that the LVOT obstruction is the independent risk factors for the outcome. This is another case with the hypertrophic cardiomyopathy, that you can start thinking, so where exactly the obstruction is. Is it formed just by hypertrophy, or are they the caudal attachments? So you can see that there is the fibrotic tissue on the crest of the septum. It's nice to use the blood speckle imaging nowadays because it identifies the most turbulent flows. And again, then you have the options how to visualize the LVOT. So this was the case with the fibrotic tissue together with the sum, so the myectomy, and then we measure the distance from the aortic valve, how far the surgeon should go with the myectomy. This is one interesting case because we did a conventional echo. We suggested there's some level of the obstruction caused by the fibrotic septal crest, again in asymmetric cardiomyopathy. And you just switch to the 3D and look at this. So again, you probably need to get the family, but you see the numerous scalps attached underneath the aortic valve to the septum. So that's much more complicated because we need to warn the surgeon and to discuss, are they the primary cords or are they the secondary cords? Can they cut these cords without damaging the mitral valve? So again, so it's a lot of discussion, trying to choose the best technique to achieve the good outcome. So this on 2D, this would be completely missed. And now, again, the view I told you. Again, emulating the surgeon's view. Open the aorta and look from underneath the valve. And you see beautifully the thumb, anterior mitral leaflet, and you see these accessory cords. So if you rotate slightly farther down, that you would see the both mitral leaflets. But it's nice view that you see dynamic structure. That's also what the surgeon don't see. So they have the heart in the diastasis. So they definitely it's beneficial that they understand where exactly obstruction is and what the mechanism is. And of course, then you can show the color where the regurgitant come, and that's another patient looking underneath the mitral valve, and you see the massive prolapse, the anterior septal motion. And we have the fancy photorealistic volume rendering, which again shows the systolic anterior motion in the beautiful mother. So it's nothing just to support the surgeon, and this is our goal for all images, and we should help them as much as we can. And we are getting close to the realistic anatomic views, which is the main progress of the technology. You can read we published the guidelines and the recommendations, and you can see that to assess the left ventricular outflow tract and aortic valve, 3D echo is the highly recommended. So to summarize, the assessment of the comprehensive assessment of aortic valve and the LVOT, it's absolutely crucial. And what we are doing, we navigate the surgeon or interventionist using conventional and advanced imaging to achieve best possible outcome. We have a technology, we have the probe. I know they are not cheap, but they will get cheaper because, of course, it's all about the market, but I'm sure that the probe will get gradually cheaper. The main benefit is that we see the real dynamic structures in the 3D without the need of multiple 2D views. And as I told you already, this is all becoming the part of the merged or fused imaging, taking the best of each modality. So as a plan for the pre-op assessment, so there will be the numerous fused images from the CT, echo, and MRI. VR is the next step, and we use the 3D echo as a part of our newly released program. We developed the program to teach the echocardiography using the virtual reality. It's been a very successful program. We are traveling, I think it was from Prague, that we bring from London 40 or 50 3D glasses. And then we teach the people how to understand 2D and 3D echocardiography. So basically, we have the CT 3D model, then we have a 3D echo, and we have a 2D echo. So for instance, for junior doctors to understand 2D echo, like in the ASD, where exactly the ASD is. Yes, we can find the hole, we can measure the hole, we can say there is the small retroaortic rim, this is the good case or bad case for transcatheter closure, but there is no chance to understand exactly the topology of the defect, and this helps, because then the trainee, they have the slicers, and they can look from inside the heart on the CT and 3D echo. So it's very, very good program, and let me finish that this will be part of the program of our already 19th edition of the European Echo course, which I'm bringing to Prague in September. And as you see, we have the fantastic faculty. So for you are quite senior, but for junior, I see a few juniors. You are very welcome to come to my beautiful home nowadays to play with this 3D and to get some knowledge from cardiovascular imaging and echocardiography. Thank you very much.
Thank you for an excellent presentation of the insight of imaging today and in the nearby future. Any questions from the audience, please? Yes, Professor Kalangos. It's over there.
Impressive presentation. Thank you very much, Professor Marek. Regarding, the systolic anterior motion, the angle between the aortic annular plan and the mitral plan is very important.
Yeah.
Yeah. Could you comment on that? And recently, in Istanbul, we had, I don't know if the pediatric cardiologist is here now. Did you see a case in a corrected transposition? The systolic anterior motion of the mitral valve is very well known. The systolic septal leaflet of the systemic tricuspid valve creating right ventricular outflow tract obstruction. Did you see a case like this? Because recently
I need to think what you are telling me. So the baseline anatomy is double
corrected
discordant.
transposition,
Okay.
28 years old.
Okay.
No VSD on echocardiography.
No VSD. Okay.
Yes, I have, the photos on my cellular phone, mobile phone, I can show you. There was a right ventricular outflow tract obstruction, 40 millimeter of mercury
Anatomic,
gradient.
so the left-sided
Corrected
ventricle.
transposition, yes. The tricuspid valve in the systemic position. And then there was a severe insufficiency of the systemic tricuspid valve. No VSD?
So the problem is on the right side, not left ventricle.
Yes.
So tricuspid valve
Left ventricle, right ventricular outflow tract
to
obstruction.
aorta.
Yes. And, no VSD. There was, several echocardiography images. And when, I opened the case, there was, an inlet VSD of 4 centimeters.
That's the issue. Yes.
Yes.
Yeah. Because otherwise it wouldn't make sense. Because you know why?
Yeah.
Because in CCTGA, aorta it's perpendicular on the inlet on
Yes,
the tricuspid
yes.
valve, right?
Yeah.
So the option is that you have the VSD and you have the tissue from the tricuspid valve,
The septal
which is the
leaflet.
very often duplicated accessory tissue, which is the balancing between the
And,
left and
protruding,
right
doing
ventricle.
a systolic septal motion below the pulmonary valve, inside, the right ventricular outflow tract.
So through the defect.
Through the defect.
Yeah.
And there was no VSD because, during it was a redundant septal leaflet closing during diastole the VSD completely.
Yeah.
Did you see
I understand
something
absolutely.
like that? Did you see?
So I would describe as the CCTJ with non-committed inlet VSD.
Inlet VSD?
Yes.
Yes, because I would like, to
non-committed.
publish in the circuit non-committed.
Non-committed.
Yes.
This is important.
But it was, I will not say non-committed. It was, purely inlet, just under, the septal leaflet.
Yeah, but it's, there's the outlet septum, subaortic, there's the LVOT. So normally the defects are close to semilunar valves. This defect, I suppose, was the more posterior, separate from aortic valve
Yes.
and pulmonary valve.
It's true.
So that's it's logical because then if you have, I've seen even the spontaneously closed VSD
Yeah.
by these accessory tissues, right?
Yeah.
Because in extreme form, you can get the straddling from each side. And these defects are typically in the inlet part. So they are the remote from...
we will send to your Congress, the images.
Okay. Yeah.
Because very instructive, this one. First time,
I
have
love
seen
these
in my-
complex cases because
Very
that's,
good.
and
I would like to send to the circulation imaging, you know, because
Yeah,
it's
yeah,
very
yeah.
clear. And,
I'm happy to have a look at the images if you
yeah,
want to
yeah,
send
you know,
some.
yes, Metan is here, you know. You can send to Professor Marek the
You
images.
know, my advantage is
Yeah.
that I am armed surgeon, so I never damage anything.
Yeah, yeah, very good. No, it's very good because we collected all the images and even, you know, you can send to the echocardiography European. Yeah, 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 very good.
Thank